Live in New York City, I'm at the MegaGen convention, and it is an honor to be with Nicolas Elian,
Yes.
Of the VIZSTARA Center. You've been doing implant training for a long time. First of all, tell us about your background with VIZSTARA and how you got into implant training.
Well, first, pleasure to meet you, Howard.
Oh.
And your lecture was truly incredible. Really enjoyed it.
Well, thank you.
VIZSTARA, my wife is a pediatric dentist and an orthodontist. I'm a prosthodontist and implant surgeon. We both have been in academic for many years, and we saw what the universities are doing, and we felt very strongly that there is a need of a private type of education as opposed to what the university does. Short-term courses, mini residencies, mentorship programs, and we've decided to build the center based on that thinking.
Well, tell your wife that I love her to death because of the 9 specialties. 7 of them are clinical, 2 of them are non-clinical, public health and oral radiology reading. But of the 7 clinical specialties, if I had to be a pediatric dentist, I would climb to the top of the building and just jump off.
You have to be a saint.
Oh my God. I love root canals. I love placing implant. I love doing everything. But a 3-year-old screaming kid, I quit.
It's not easy.
I would go work at McDonald's in a second. So tell your wife thank you for taking all the children. So what did you think the public schools were missing where a private solution would help?
Well, you know, normally to advance your skill sets, some people think I'll go back to school and I'll do a specialty. Today in the US, most specialties are 3 years full-time. And of course, I know you mentioned it yesterday, they will need another maybe $500,000 of debt to make it happen.
Right.
Our environment does not create a specialist, but we do deliver a super dentist. Dentists come to us for short periods of time. They learn surgical skills, prosthetic skills, endodontics, orthodontics, across the gamut. And of course, some practice management. We are going to need your help.
So you're teaching VIZSTARA. Where's that at? Is it New Jersey or New York?
It is in Englewood Cliffs in New Jersey.
New Jersey, but that's
Well,
close
it's about
to New York.
10 minutes from once you cross the bridge.
Can I get
George
there
Washington Bridge.
in that new tunnel Chris Christie dug from New Jersey?
Yes.
Isn't there a new tunnel that he dug? Did he dig that himself? I'm just kidding. Local joke. So you're a prosthodontist?
Yes.
And an implantologist?
Yes.
Yeah. Okay, so what % of the general dentists in America would you say place implants versus do not? I mean, wouldn't you say that 9 out of 10 dentists have never placed one implant in their life?
That sounds about right, because my understanding and the statistics that I see, there are only 20,000 GPs in the US probably placing implants at different percentages. The problem with that, education in dental schools related to implant surgery almost non-existing in undergraduate programs. So therefore, every young dentist that is graduating dental school today and years to come, until there is a particular training that is implemented in the curriculum, they will have to look at centers like ours to come in and learn and train.
These podcasts are listened to dentists from every single country on earth. So to all the non-US dentists out there listening, I just got to explain to you that like I also have a Orthotown magazine and website, and it goes to all 10,500 orthodontists, but there's only 17,000 orthodontists in the world. So America is very divided up by these 7 specialties that you don't really see in Brazil and most of the world. So when we go to dental school, they're not going to teach us something that the specialists want for themselves. Like I got 0 ortho training. So the specialty that they want you to be a general dentist and just do fillings and crowns and refer everything out. Sure. In America, America is really not based on truth, liberty, justice, the American way. America is based on money's the answer, what's the question? So what I want to talk to these people is if 9 out of 10 have never placed an implant, before I tell them instructions on how to drive from New York to Miami, I want you to address why should a general dentist listening to this podcast on her way to work, why should she learn how to place an implant?
Sure. If I can add to your point regarding the difference between the U.S. and international markets. As you well know, the U.S. is a specialty-centric market. The rest of the world is the GP is really the captain of everything happens in that office. In the U.S., that model is changing. I'm a prosthodontist and I've trained in surgery. I have been training restorative dentists for the last 20 years, learning implant surgery. Periodontists today, the American Academy of Periodontology requires that periodontists are familiar in temporization, so they're learning restorative and building restorative skills. The Endodontics Academy made it a requirement that endodontists in training must learn implant surgery. So the boundaries of the specialties are very different now. They're no longer as defined as we think they are. For the restorative dentist now, it is a must, because introducing implant dentistry in their practices, it is income, it is money. Because once they introduce that surgical skill into their practices, we see it in our mentorship programs, they increase their revenues by 15 to 20% year one.
Well, I want to also remind everyone that there's two Americas. So half of America lives in 117 towns over 100,000, and the other half lives in 19,022 towns under 100,000. And a lot of these dental schools are paid by state tax money, and all these rural people are paying for these public schools, and then they educate a dentist to go back to a very small town of Eloy, Arizona, and there's no you don't have any specialists in these small towns. So when specialists say, well, if you need to do that, you should send them to one of us. Hey, dude, you're only in half of America, and the other half paid for your school. When you walk out with student loans, your tuition and student loans, you only picked up about a third of your tab. The taxpayer picked up the other 2/3, and I think it's an insult to send dentists back to rural America and they don't know how to do any of the 7 clinical specialties. So, you know, because I know humans, and when you're in a small town and the big city's an hour away, and you say, well, I can't do a molar root canal, but you need to drive an hour into the big city, well, you know that old man's going to say, forget it, pull it. So the fact that the economic barrier to entry is an hour drive, he just elected to have his body part pulled out and thrown away because you can't do molar endo. And I'm telling you that you know healthcare's got to be accessible, affordable, easy. And when these dentists in rural America learn how to place an implant, they say, dude, I can do it right here. It's not that big a deal. I can put that implant in right here. The care goes up. So quality, so there is 2 Americas. There's urban and rural. And I wish all these rural dentists would learn molar endo, implantology, whatever.
Well, I think it is happening. We may not be seeing it at the scale that we would like. We see the demand on education and how often people are looking to attend these type of courses, Howard. The challenge in implant dentistry, which is slightly different than endodontics, when the endodontist thought it is a danger for them that the general dentist does endo, they've realized over time that the more general dentists did endo, their growth went even higher. And I believe the model is the same in implant dentistry. As a specialist and enjoy education and being passionate about it, I find that the more I train dentists, the more referral I get. So it is really about expanding the pie. It is not about who's taking a piece from someone else.
Rising tide lifts all ships.
Sure.
And I don't even trust an endodontist who can't place an implant, because if you send a failed root canal to an endodontist and all he can do to make $1,000 is retreat it, he's going to retreat even if he thinks it's broke, it's fractured, it's hopeless. But I'll try, because humans can rationalize anything. But those endodontists in Phoenix that I refer to that say, you know what, I can make $1,500 either way. I can do a retreat, I can pull and do an implant, I can do it both ways. I'm gonna pull this tooth. I think the first guy that did it found all the canals. I think he tried well. It just didn't work. So I think all endodontists. I think, and very shortly, I think endodontists who can't pull and make money pulling and placing implant are going to be under serious downward pressures.
Well, during my lecture earlier on, I talked about treatment planning, and one of the elements of treatment planning that we talk about is to reduce morbidity and treatment time. So think about this. I'm a patient, I'm at the endodontist, I'm already anesthetized, and he or she finds out that this tooth is hopeless now. So what they're going to do? They're going to tell me just go see someone else to do it? Wouldn't it be a greater opportunity for them to actually be able to extract and place an implant for me?
Okay, so let's talk about that. So implants have changed a lot. So you pulled that tooth right there on the spot. Are you do you like extracting and placing an implant at the same time?
Well, in today's implant dentistry, if we're not doing that, I think we are actually making a huge mistake, because placing an implant immediately, one, eliminates 2 or 3 surgeries following extraction, and of course, with new implant design like the AnyRidge from MegaGen, not only we can place the implant immediately, we can also immediately temporize it. So actually, patients leave functioning.
So you would pull the tooth, and you would place the implant, and you would temporize it, so they would leave with the tooth.
Exactly.
And would that tooth be for aesthetics, cosmetics? I mean, would they actually be chewing on that tooth?
You know, I think in the last day and a half we've debated that topic quite a bit. Some of us believe that it should be out of occlusion, but my comments in that regard, that once the patient is chewing and functioning, even if clinically it is out of occlusion, that implant is subject to load. So our thinking is really changing as we speak.
Yeah, a lot of people think the half-life of dental technology is only 3 years. I mean, everything's changing. Okay, so back to this person. What I want you to focus on is the people listening to this. 9 out of 10 have never placed an implant. Show them. Okay, so they decide they're on the first floor and they're going to go to the second floor. What would be the first couple steps? Pick an easy case, a scenario. What's the low-hanging fruit? What would be the implant that Stevie Wonder could do? Or
sure. You know, in most practices, Howard, there are probably multiple 3-unit bridges that eventually over time fail. So if we look at that 3-unit bridge that failed and that edentulous area, the pontic, so that's a healed ridge. Generally speaking, there is sufficient volume of hard and soft tissue. So this is the first area that somebody that has never done surgery that should get introduced to. At our center at VIZSTARA, we have a clinical mentorship program. We call it Implant Mentorship Level 1. Dentists come to the center. They learn how to place implants on these type of cases. Once they graduate from that mentorship, they qualify for the International Congress of Oral Implantology Fellowship status. And during that course, they are placing 20 implants on their own patients.
I got my diplomat in the International Congress of Implantology, and you know what I liked the most about it? Was meeting lifelong friends. You know, it was the friends you met. I always look back at all the CE I took. Like when I took my first course with Carl Misch. The most favorite thing about it was meeting Steve Rasner. You know what I mean? I have a friend from each one. So VIZSTARA, it's VIZSTARA, and the VIZ, that was your vision of the future.
The vision of the future.
And it's in. Did you say it was Englewood, New Jersey?
Englewood Cliffs in New Jersey.
Englewood Cliffs in New Jersey. So if you go to VIZSTARA, now tell us again what didactics you teach. Implants,
endo, orthodontics, restorative dentistry.
Wow. So 4.
Yes.
And you said practice management?
And we're always looking for help in practice management. So hopefully we'll have you at VIZSTARA in the near future, guiding some of the young dentists graduating from dental school in their career.
That sounds amazing. So this person is listening to the podcast driving. Talk about the implant didactic. Is that a weekend course, a 3-day course? Is it 3 courses?
So there are 1-day courses and 2-day courses, but we feel in implant dentistry the introduction to basic implant dentistry is a 4-day course. During that course, I'm doing actually live surgeries. they're observing over the shoulder.
Is this a Monday through Thursday, or
that's a course that we have from Wednesday to Saturday.
Wednesday, Thursday, Friday, Saturday.
Saturday.
It'd be a 4-day course.
4-day
this is your
course.
intro level to implants.
Yes.
Yeah.
So what we find in that course, that attendees, once they've observed over the shoulder and learned the basic science and clinical science of implant dentistry, some of them, they will elect a mentorship program. And so once they make that decision, level 1 mentorship, it is a 20 session, because we want them to place 20
sessions?
20 sessions, 20 full day sessions.
20 one-day classes? So
Yeah.
they would come back to
Yes.
Inglewood Cliffs, New Jersey,
Yes.
20 times over a course of what, a year?
But usually is a year, because we'll give them also at the end usually 2 sessions as a make-up if somebody didn't finish the requirement that we're asking for.
Mm-hmm. Wow. So that's an intense curriculum.
Yes.
So it would start, so let me get this right. It would start as a 4-day, Wednesday, Thursday, Friday, Saturday,
Yes.
and then 20 more
Days.
one-day class. 20
Yes.
days or 21 day at a time?
21 day at a time, alternating. So as an example, we have a mentorship that takes place on a Wednesday. So alternating Wednesdays, they come to us twice a month.
Mm-hmm.
And during that one full day, they're treatment planning. They're learning how to read cone beam CT. They're learning diagnostics. They're learning how to do implant surgery step by step on their own patient with 1-to-1 faculty ratio, which is unheard of even in the best postgraduate programs.
And after the 4-day start and the 20-day follow-up, what do you think that person's surgical, what could they be doing in their office?
I think any healed ridge in their offices, there are
any healed ridge,
they're able to treat with confidence and with high predictability. Here's what we do that is unique once they complete that course. For 1 year, we ask them that they should send us their CTs and their photographs to work with them on their treatment plan to make sure that actually what we have done is accurate and is allowing them to actually practice and do implant surgery in their practices.
So, so this, my whole mission with Dental Town is using the internet, now the smartphone, to connect dentists so that no dentist has to practice solo again. I mean, I thought it was very painful when I would come home from work and I would be alone with my 4 little baby boys, and I'd be stressing out about, I did a root canal and it swelled up, and should I have pulled it or put them on antibiotic? I just wanted to talk to someone. And when my boy was, Eric, was 9 years old, he was born in '89, so in '98 he walks to my office and he says, hey Dad, can I borrow your credit card? And out of morbid curiosity, I said, of course, you want to see what your 9-year-old's going to do with your credit card. And he logs onto this stupid AOL dial-up and all this crazy crap that we had to get for his homework. And after about 15 minutes of this AOL dial-up, he gets on this website and he's talking to other kids about skateboard wheels, and then puts in my credit card for $100 for these wheels. And I just look at it and I go, oh my God, I want to be talking about root canals. And it was just the greatest thing. And I think what these dentists need, they're all alone. So their whole circle of friends, they don't place an implant. No one places an implant. These courses like these are game changers, because you're going to go there, you're going to have a mentor, you're going to have a friend, you're going to meet classmates. And these are decisions that you make, and then a year later, you might be placing 5 or 10 implants a month, right?
Sure. Actually, that's quite interesting, Howard, for somebody that just learned implant dentistry and took the course. So recently we started to offer them an opportunity in the early stages that you may not be ready to invest $15,000 or $20,000 buying an implant system in your practice. And of course, the cost of cone beam CT that is very high. So what we offer them is an opportunity to continue to come to the center. Now they're treating their own patients. But also remember, these are people that we have trained, we know their caliber and their level, so they're already vetted and accepted to be at the center. They bring their patients. We have a huge inventory of implants, so they don't have to worry if they have the right size or the right implant. If they need bone grafting, we have large inventory of bone grafts, membranes as well. And in the event that there is a challenging case, they have us as their backup
So you're saying the doctor could bring a patient and do it at your center?
Yes.
But what about the licensing? I mean, what if I'm from Arizona and I have an Arizona license, I don't have a New Jersey license?
So we have ADA CERP accreditation for our courses. Anyone that is enrolled in the course can actually treat their patients during the course at VIZSTARA.
Now, is that in New Jersey can do that? Or?
In the state of New Jersey, you can do that.
Wow, that's very rare. Most states will not let
allow that. Yes.
Wow, that I did not know. So has that been that way a long time, or?
Well, I've personally only learned about it when I applied for the ADA CERP, and we've learned that actually any dentist from the U.S.
Now in Arizona, if you're doing it at a charity house, so there's a couple of charity places in Arizona where it's just dental, St. Mercy, or a couple of little deals, and if you have the course there. And the dentistry's on one's for homeless vets and one's it's good there. Yeah. That's an interesting thing. Okay, so again, this dentist is all alone. He's looking at the market. It's very confused implants. I mean, there's implant companies like Noble Biocare that are very high cost, probably over 500. Probably 40, 50 companies all the way to very low cost down to 100. Do you get what you pay for, or is it implant? Is titanium? What should this dentist be thinking about? What should the dentist be thinking about when they look at 50 different implant systems?
Well, the answer is yes and no. Implants maybe look very similar, but also at the same time, there are huge differences. It all boils down to the quality assurance that a company has. And of course, you want to work with companies that have good reputation, that very consistent in their quality production. And also, very importantly, I tell everybody to focus on who are the people behind a particular company. In the case of Megagen and IDS, Dr. Park and Carrie Lyons and Steve Pfeffer, they have been in the industry for a very long time. And yes, they're selling a brand, the Megagen and Any Ridge implants, but also I think they're selling their names and their reputation. They are a brand as well. So they're very careful with that, and they will not be associated with anything that is not of high quality.
I'm going to ask you I'm going to give you 3 words, and I want you to talk about them. On Dental Town, I always like to look at the search data. So we have 50 different forms, root canals, fillings, crowns, all that stuff. But on implantology, people are always searching screw or cement. They're always searching immediate load or not, and platform. What is it?
Platform switching.
Platform switching.
Or not.
So can you talk about? I'm going to start again. So tell me, do you agree with this premise? When impressions go to the lab, 95 out of 100 impressions are just for one crown. Would you agree that when implants are placed, 95 out of 100 are just one implant going in for missing one tooth, and only 5% are big cases? Would you agree with that?
That's definitely what we see in our center. The majority of implants that we are placing are single tooth implant.
Okay, so for that single tooth implant, the dentist is always asking, would you just cement that, or would you do the screw retained? What's your thoughts on that?
As you have probably already seen, the issues with peri-implantitis and the big question of cement not being cleaned from the sulcus. So that is always a concern, that someone may not be able to clean the sulcus properly. If the implant is in the right position, I think just a question of preference for the restorative dentist. Some of them are very comfortable cementing and cleaning the cement out. We find that there is a larger number nowadays that is leaning more towards screw retained. At least in our environment, that's what we are seeing.
So what do you do personally? I mean, if you did 100, if you put 100 single tooth implants in, what % would you screw down versus cement?
So in our training, Howard, we work very hard on not only placing the implant, but creating an environment surrounding the implant. And that is part of our treatment plan. And in the courses, we emphasize that. So doctors are not only learning how to place implants, they're learning how to provide a better treatment plan. So in that regard, we place our implants probably 95% in the most ideal position. That's the center of the central fossa of a posterior tooth, center of buccolingual, center of mesodistal. And in that particular scenario, we find that screw retained is more cost effective in our environment, faster, simpler, and less visits.
Okay. And when would you do an immediate load, and when would you not, and have them come back, 3 months later?
So immediate loading is such an interesting concept and life-changing experience, I think, for both the dentist and the patient. As a protocol in single teeth, anything from the second bicuspid moving forward anteriorly, it is immediate implant placement, immediate temporization.
For the front 10 teeth, upper and lower?
Lower.
So the front 20 teeth, second bite to second bite, would always be 99% of the time?
99% of the time.
Would be an immediate load with a
provisional.
With a provisional.
With a provisional.
Wow, that's amazing.
In rare occasion that we find that, a completely blown out sockets that we can do it, but that is very rare. We don't see these type of cases.
And will you explain for the, again, platform switching seems to be a concept a lot of people have difficulty with. They're always trying to, they never, and even when people explain it, they still don't get it. So will you try to explain platform switching? And is it even important? I mean, is this something
yes.
they need to know about?
I think it is important, and I think it's an important concept that we simplify it and make it clear. The reason for platform switching is to provide better aesthetics. In that we mean more soft tissue around the head of the implant, or at the junction between the implant and the crown. What it is very simple. The abutment is a smaller diameter than the body of the implant itself, and that allows or prevents crestal bone resorption and a greater volume of soft tissue. It is a concept that is here, it will stay, and truthfully I cannot think of an implant that is not platform switched on the market today. Okay,
and so I'm going to ask you, what are your most common implant questions when at your institute?
We've been looking at the trends in soft tissue changes. While we place the implant and we can get great results, what we find that over time that the volume of soft tissue around an implant is usually less than what it is around a natural tooth. So we are finding that we really have to enhance more soft tissue on the buccal. So this is an area that we keep asking ourselves, do we need it? Is it really necessary? Do the patients benefit from it? And how can we show its value? I think we're making headways because the education that we're doing, I believe practicing dentists, and they do have the relationship with their patients, they're making a very good case for it. And I think we will see more and more soft tissue graftings around implants.
Do you want to switch gears to, you also teach endo and ortho?
Yes.
So let's jump into endo. What in your career, do you think like 3D, going from 2D radiographs to 3D has changed implantology with surgical guides and diagnostic plan? Do you think 3D CBCT is changing endo? Because is it safe to say that the #1 cause of a failed root canal is a missed canal, and this can be eliminated with CBCT? Do you believe that statement?
I without a doubt, I think we're seeing so much more of it. The challenge is, can every dentist have a cone beam CT in their office? So that's one. In regards to the endo, I just want to make sure that I'm not misrepresenting this. I personally cannot teach endo, so we have somebody.
You can't teach endo?
Not myself.
Why?
Because I haven't done endo for the last 20 years.
Okay.
But we have an incredible endodontist and incredibly talented clinically and as a teacher, Michael Feldman.
Yes.
So the endo courses that we do, he usually runs these courses, and he puts a lot of emphasis on diagnostics using cone beam CT.
Does he have any favorites? Do you have any favorites for 3D X-rays for implantology? Does he have, and is his favorites for root canals the same as your favorites for implantology?
Actually, we have two different units. He has a Kodak in his office, Carestream, and we have Galileo's in our office.
Okay.
I think in terms of quality, and this is probably similar to what type of implant do we select. The majority of the units that I have seen and I have read scans from, they're of high quality. VETEC is doing a great job. I've looked at some of their imaging.
For CBCT?
Yes.
VALTEC?
VETEC.
How do you spell that?
VATECH.
And they're out of?
They're out of New Jersey, actually, I think.
They're out of New Jersey?
Yes.
Really?
Yes.
Interesting.
So they have a very interesting unit.
CBCT.
Yes, and it eliminates scatter better than some other units. But at the end of the day, there's a lot of similarities. It's a question of comfort, learning the software, and of course cost.
Now, if you have Galileo's, let me just go back to your question. For a single implant placement, for this listener out there, 90% of them have never placed an implant. They're going to place their first one. When they place their first 100, would you? But just so you've already got two teeth guiding you.
Yes. And
you can see the buckling. Well, they know how bridges draw, so they have two teeth. Would you recommend a surgical guide for their first 100 implants, or not really?
So Howard, in all my years of education, this question has come up on many committees. When I ran the Division of Implant Dentistry at NYU, we've debated this at length. While a surgical guide is very important and very useful, for the novice, I think it is a limitation, because you're minimizing their surgical skills. You're making them depend on a device. So you're not allowing them the opportunity to build surgical skills. And what do we take away from them when we give them a guide? We take visibility and we take tactiles. So therefore, we're not building any skills for them. So in our curriculum and what we do, as a matter of fact, all the beginners don't use cone beam CT because they're placing one single implant. There's a mesial tooth, there's a distal tooth. They see the buccal very well. So we make sure that it is in the center of the mesiodistal and buccal lingual. But here's what I can tell you. In that particular case, guided or guideless does not make a difference. But what makes a difference if it is thinkless? Because some people just sit there and think it is just placing a screw inside the bone, and that's unfortunately when we see problems.
Very well put. That is very well put. And I also want to ask you, when you're looking at, you're placing an implant, and you're doing you've laid your flap, you're about to go. Do you personally like to look in from the side, or do you like to pull the patient's head right in your lap and look straight down? What do you do? And are you stand up or sit down?
I sit down all the time.
You sit down.
I sit down all the time. But this is also quite interesting.
I've never pulled a tooth, a wisdom tooth, or placed an implant sitting down. I do all my fillings and crowns and root canals sitting down, but I have to stand in surgery. I don't know why.
Now I feel terrible because everything I do is sitting down.
That's interesting. So you're sitting down.
I'm sitting down.
Where's the patient's head?
So this is quite interesting. Actually, I'm going to find out a way how we are going to provide you this material, because in our course, we eventually decided that certain teeth, let's say tooth number 5, right? Tooth number 5, it's maxillary right central incisors for the international viewers. So we've decided, okay, when we are training dentists, where is the patient and where do you sit? So we have diagrams in our manuals that I'm going to send them to you, that you decide where you want to put them on your website, because it tells every dentist for each site where the patient's head is. So for instance, tooth number 5, the patient turns their head to their left. The doctor is in a 9 o'clock position. They have complete visibility. They see the buccal, they see the central fossa, and they place the most accurate implant that they can be. Well, that's, as I said, guideless. But the most important part, it is not thinkless.
Yeah, I think it's interesting that whenever you get into full mouth rehab and you're gonna, all the teeth are gonna be prepped, every lab man can tell you if that dentist was sitting right-handed or left-handed. Because they're always they're one way or the other. They can all tell. So okay, so back to endo. What is the what percent of the 120,000 general dentists in America would you say do not do molar endo? How many of them just say I don't do molar endo?
Howard, I must admit I am not familiar or knowledgeable of that statistics.
And what I'm reading is half.
Okay.
So I'm reading 9 out of 10 have never placed one implant, and half will not do molar endo. Okay. And that's just every time I see the number. So this person's either usually we do these every day. So you'll get more views on Dental Town, YouTube, iTunes. So probably 3 or 4 months from now, 1,000 people have watched this on Dental Town, probably 300 on YouTube, and probably 2,000 to 2,500 on YouTube. So about 2/3 are just listening. So this person's listening to you right now. They're driving an hour commute to work. They don't do molar endo. They hate it. They say, dude, I'd rather get a paper out than do a molar endo. What is this person missing? Why does he hate molar endo? And do you think you could turn him into freshening up the love affair with molar endo? Because the reason I like molar endo is, number one, they come in there in pain. I'm not trying to sell you a smile lift or veneers, and I don't even like selling cosmetic dentistry, because I think when you go up to a woman and say, you should get veneers, she's probably looking at me saying, yeah, you should lose 50 pounds, get a tan, and wear a wig. I mean, I don't like to tell people, I wouldn't like to every time I go somewhere, someone's telling me I should get a wig or whatever. But they come in with a toothache. That's an easy sell. They're in pain. And a root canal is $1,000, and insurance pays 80%. I love them. And it really blows my mind that half my colleagues hate them. Don't do it. I mean, who doesn't want... And I feel like a hero, because you came in like, God, I can't even sleep last night. And then you leave like, thanks, Howard, and they're out of pain. And, so it's a hero. It's $1,000. Insurance pays 80%. Talk to this person. Do you think your center... VIZSTARA could get them fired up in molar endo?
Without a doubt, Howard. While we're very passionate about education, we're also very passionate about making dentistry better. I think in any discipline or any area, such as the molar endo, when people don't get involved in it because, truthfully, they have not had the proper education. So our model is based on what we call hands-on, practice-based clinical training. So yes, I can sit in a lecture room and listen to someone talk about molar endo for half a day or a full day. That does not necessarily translate into me going to my office and doing molar endo. In our model, it's not only that we make sure that dentists are knowledgeable in the didactic component. Immediately after that, they're in the operatory and they're performing molar endos under supervision with incredible faculty of the highest skill and talent and commitment to education. I have no doubt that we can fire them up. They go back to their practices, and the next day they're doing endo in their own offices.
So do you like any of the automatic rotary night eye systems?
Oh, well, of course. I mean, I don't believe that today we should be doing much endo without having rotary component in the practice. But hopefully, we'll get you to VIZSTARA to visit, and we'll have an interview with Michael Feldman, and he will talk about the different systems.
Have him call me, and I'd like to do a Skype podcast. Most of my podcasts I do via Skype. Because we're not in the same city. Have him send me an email, howard@dentaltown.com, and I would love to do a Skype system, because a lot of these dentists, they see all these different file systems.
Yes.
And again, they're trying. I try to give them a stairway. It's kind of like if you were going to leave New York and go to New Jersey, they need to first know, okay, when I pull out of the Grand Hyatt, do I go left or right? What course would you recommend? You say your center, what file system? I'd like more of that. So the other one you taught, so you teach implants, endo, and ortho?
Yes.
And who teaches your ortho?
So in ortho, we have two orthodontists on our team, Dr. Martha Mikeo and Dr. Frank Salenza. They're both incredible orthodontists. They both have been in education and in private practice for many years. And again, also in ortho, we use the exact same model. We are hands-on, practice-based clinical training. So yes, there's a didactic component that the dentist needs to be familiar with, and immediately after that, it is getting them into the operatory, seeing patients, and actually doing it themselves.
And you know, another interesting thing about the specialties is like if 95% of implants are one at a time, if 95% of crowns are one at a time, in ortho, 80% of ortho is class 1 molar, class 1 canine, 15% are class 2, 5% are crazy class 3. You know, the one advantage of a general dentist is you can cherry pick the easy ones.
Sure.
I mean, you could do the easy cases. I mean, you know, there's a big difference between replacing one single missing tooth with an implant versus some lady can come in with a full set of dentures with no retention, no ridge, no jaws, and says, "Can you make this work?" I mean, that's a. And by the way, on that case, to the advanced listener, grandma comes in. She says, "Doc, full dentures. I can't eat. I can't chew." You take them out. She's very flat ridge. She's had these dentures since she was 20, and now she's 65. What would you do for this case?
So obviously that puts this patient in the advanced category or possibly a high risk case depending on the bone volume and soft tissue volume. In our environment, while that case might be an advanced case, we have the skill set and the tools to teach how to build bone. If you don't have the right volume, whether height, width, the quality, we place implants if the desire is something that is fixed. But also I'm a great advocate actually for overdentures. You know, there is always a spot in the mouth where you can get 1 or 2 implants, and if the mandibular denture, you can place a locator or another type of attachment and give them that security.
One thing that's that you always hear people talking about, like sometimes when people, you know, it's kind of weird. It's like there's this big religion in dentistry to preserve bone and save bone and grow bone and bone graft. But a lot of times you see these people, in order to get a bar, are just mowing the bone down.
Yes.
So there's some implants where you just have the implant in a little ball and the denture snaps on. And then other implants, you know, you need to connect them all with a bar, but that takes a lot of room. Will you talk about tree implanting? I mean, or if someone came in with a full denture, what % of the time would you do an implant bar over denture versus just implants with balls and snap down?
You know, I think in terms of the quality of the denture, if it's an overdenture, I think you'll get very similar retention, if not better, with 2 implants and a locator attachment, and patients will do very well.
A what locator?
Locator.
Okay,
there's an attachment that is called locator or O-ring. There are a few Ryan 83. There are a few different attachments on the market that can do a very, very good job. That's very interesting because now the patient can actually remove their denture and also clean the implants. So in terms of hygiene and long-term maintenance, it is a great model. I don't believe that you need to have a bar to have an overdenture. It is not necessary.
Now, was that a concept that Carl Bish pushed a lot because he just liked the physics that if you had 4 implants, whenever you connect them together, the geometry, the physics, the forces are better?
Sure. So yes, if you already have 4 implants, and we've heard the last couple of days at the symposium, the concept of all-on-4 and immediate loading and temporization. If you already have 4 implants, the chances are you can have something fixed. Now, I think if we had 5, we'll make it better. But here's the issue in regards to your question, leveling the bone. I do have a concern because if we are leveling it to an extreme in 4 or 5 millimeters, I think we're creating situations that are much more challenging for our patients to maintain, even for ourselves. I think if you look at some of the cases that are treated with that modality, where you're leveling the bone and you're reducing about 5 millimeters, your hygienist is going to have a challenging time cleaning that case.
But some of these dentists, I want you to weigh on this on the clinics. Some of these dentists say, okay, obviously if you take out your denture and there's 4 implants, is that Dr. Art? How are you doing? A lot of people say if I take out my denture and I have 4 bowls, you know, the patient can clean around it and brush. If it's connected with a bar, it's harder to brush and clean around. The gums are inflamed. But a lot of dentists say, okay, the gums are inflamed, it's periimplantitis, but it's not a game changer. I'm not going to lose my implants from chronic periimplantitis. Do you agree with that statement, or do you not agree with that statement? You know, in fact, Gordon Christian, he believes a lot of periimplantitis is just a reaction to the metal. Like you know, some people will wear a ring and they'll get a green tattooing around it.
Yes.
And some people wear that base metal ring and not. Gordon thinks a lot of the periimplantitis is actually just a metal allergy.
Howard, I was hoping that you'll ask me what is the cause of periimplantitis.
What is the cause of periimplantitis? That was my next question. And then I'm going to ask Art Boker the same one after you.
You know, I tell everybody, I think periimplantitis is really in your treatment plan. You've already missed something in your treatment plan and you did not account for. So, take the bar as an example. In the decision making that we have 4 implants and we should have a bar, usually you're stuck. You have very limited space. Your bar is very close to the soft tissue. You cannot clean it as a dentist. Your hygienist cannot clean it. You cannot expect your patient to clean it. Is it periimplantitis? Maybe not. But here's the concern that I have. It is an inflammatory process that is in somebody's mouth. Does it affect heart disease? Does it affect diabetes? And I think our responsibility as dentists to provide a healthy environment. How do we provide them with that? A treatment modality that actually they can maintain at home.
Well put. Well put. Well, I would like you, your 2 orthodontists to call me and Skype a podcast too. I'm
going to make sure that Michael Feldman, Martha Mikhayo, and Frank Salenza, they'll reach out to you and.
So you teach implants, ortho, endo,
anything else? And restorative dentistry.
And restorative dentistry?
Yes.
Does your wife come in there and teach pediatric dentistry?
Well, she is an orthodontist and pediatric dentist.
And which one does she like more?
I think she likes ortho more, but obviously she's very passionate about what that combination between ortho and pedo.
And what does she recommend for pediatric dentistry? The dentist being on nitrous or taking an Ativan before the appointment?
I'm going to let you ask her that question when you interview her.
I want to interview her too. Okay, so my last question is you're lecturing at the Medigen Symposium, 11th Annual Medigen Symposium. What were you lecturing about? What was your lecture about?
Well, my topic was controversial concepts and therapies in implant dentistry.
So do you have time to run through some of that?
Sure. You know, you've asked me earlier about immediate implant placement and immediate load. And while for the way you've just described it, what we have in the U.S., we have the city dentistry and the rural dentistry. And unfortunately, even in the city environment, some people think this is a concept that shouldn't be done. We've been doing it for a very long time, and I shared some of our experience at the meeting. My very first immediate implant placement and immediate loading was done as a dental student, 1993. I tell everybody I was a non-obedient graduate student, and I questioned the science. I questioned our clinical skills and if we can do better. So it is an area that I've done a lot of work in over the years, and learned the limitations and the potential opportunities. We don't have patients that walk out of our office just taking teeth out.
Well, it's kind of funny because I'm older than you, and in 87, everybody would, on a root canals, 2 appointments. The first one, they'd find all the canals, get all cleaned out, and then temporize it. And I'd say, well, why do you temporize it? And they say, well, to make sure it's okay. Then I have them back in 2 weeks to fill it. And I said, okay, well, what percent of the time when they come back in 2 weeks do you not fill it? They go, I always fill it. I'm like, so you wait 2 weeks to check something, and it always checks out okay.
That's okay.
Well, why don't we just fill that baby now and get rid of that second appointment?
Sure.
And people just literally thought you're crazy. And I also want to tell you something else. When I got out of school in '87, the very few people placing implants, it was about a third subperiosteals, about a third ramus bars, and a third root forms. They were all considered quacks. Where I went to dental school in Kansas City, where I practiced I mean, I remember walking into meetings, and there was the good oral surgeons who did exodontia, and there were the weirdos over there sticking metal into people's jars, and they were all viewed as quacks. And some of them around the United States literally had their licenses taken away because they do a big case, and they were doing lots of them. But the first time a big case failed, they took their license away. That was common in the '80s. There are, so it's amazing how things change. Amazing how much it'll change. But hey, I just want to tell you, you're a busy man. It was an honor and a privilege that you gave me an hour of your time.
Howard, pleasure meeting you, and thank you for the opportunity. It's been pleasure getting to know you. And
I want to drive by your center and see it myself.
I would love to bring you over.
How long of a drive is it from New York City?
15 minutes.
15?
Yes.
Are you open? Is that where your clinical practice is?
Yes.
So will you be there Monday?
We don't practice on Monday, but
will you be there Tuesday?
No, I'll pick you up on Monday and I'll bring you to the center.
Well, I want to see it. I cannot wait to see it.
We are going to make plans. I'm going to pick you up and bring you over.
Okay, it's a date.
Maybe we'll get you some Lebanese food in our area.
Obviously I like all food. I've never found any food I didn't like. Food is my favorite vice. But thank you again for your time.
Thank you. It's been great.
All right,
thank
buddy.
You.
Bye-bye.